Good morning, everybody. I can see lots and lots of people coming in at the moment. I'll just let everyone sort of trickle in. Great. So good morning, everybody. My name is Anna Granger, and I'm one of the directors here at Claremont. So welcome to today's webinar, the latest in our behaviour change series. Thank you very much for joining us. So today we're going to be discussing a long-standing and challenging problem in the field of medical research. Historically, the majority of clinical research participants have been white, middle-class men, and this has meant that women and people from non-white backgrounds and more deprived backgrounds might not be being as well served by the diagnostic tools, the interventions and the treatments that have been developed as a result of this medical research. So in today's webinar, we're going to be exploring what can be done to address this. How can we make health research more relevant to the entire population? We'll be looking at various ways to improve recruitment strategies overall, as well as the role that behavioural research and strategic communication can play. So just before I give a rundown of the session, if you haven't done so already, please can I ask our attendees to introduce yourselves in the chat. I can see people starting to do that already, so that's great. So please just let us know your full name, where you work, as well as what you are hoping to get out of today. So please be aware as well that we are recording today's session. A recording link will be made available on our website following the session, and the link will be emailed to all attendees as well. So as you know already, and you can see on your screens, we have a fantastic lineup of speakers waiting to tell you about their projects and their learnings today. As we're in the very fortunate position of having so many speakers and so many panelists waiting to talk to you today, I'm not going to introduce every single one in detail right now, but I will do as the session progresses. So just to give you a recap of what's going to be coming up, we're going to be starting off with a discussion with Dr. Aziza Sasay, that's with myself, and we'll just be talking about the problem, about the lack of diversity in health research, and also why it matters. We'll then be hearing three important health research projects where recruiting a diverse cohort of participants has been one of the priority objectives. So first of those, we will hear from Laura King and Ian Fannon, who'll be telling us about the NHS Gallery trial, which successfully recruited over 140,000 people who were proportionally representative of the population. Next, we'll be hearing from Annika Ladver and Kirsten Purvis from Our Future Health about the work they've been doing with Our Future Health, which is the world's largest medical research programme to date, to make sure it's ethnically and socially diverse. And then finally, we'll be hearing from Byron Tibbetts and Tim Parry about the work that they've been doing to recruit a large cohort of people with severe mental health problems for the Global Mind study. So we'll then move on to our panel discussion, where we will be joined by two more fantastic speakers, Emma Liddington and Professor Frank Chinagwando. So if you have any questions at all that you'd like to ask, please do post them in the Q&A during the session. We will do our best to address as many of these questions as possible during the panel discussion, or the speakers themselves might respond to those as well as we're going through. So without further ado, I think we've already there. I'm going to ask all of our speakers, apart from Dr. Sasay, to turn your cameras off. And Dr. Sasay, we will begin our discussion as well. So Dr. Aziza Sasay, as you may know, is a GP educator, and an honorary senior clinical lecturer, as well as being a very well-regarded health content creator, including on her own platform, Talks with Dr. Sasay. So thank you very much for joining us today. I've got a few questions that I'd like to ask you to sort of help us understand a bit more about the problem that we're dealing with. So first off, can I ask you to tell us about what it is you do and why this issue, and why this issue to do with health inequity matters to you?
Of course. Thank you so much for having me, and well done for putting this together. It is so important. I'm hoping that this discussion will lead to actionable change, because often I find that it's getting to a point where we're almost admiring and glamorizing the problems that exist, and we need change. So yes, I am a GP, as you mentioned. I am someone who's very, very passionate about health education, awareness, and advocacy, and I run through my platform, which you've mentioned, Talks with Dr. Sasay. I'm very, very much in tune with the importance of being proactive versus reactive, which I feel has been the case for quite a long time. I'm very passionate about health equity, and I always emphasize equity versus equality. Yes, it's important that the treatment is equal, but more importantly, that it's equitable. And I always give the same example of, for instance, women who are diagnosed with breast cancer and who've had mastectomies, who are given, again, equal treatment in that they're given breast props that are white or Eurocentric. So they're given the same thing, but it's not equitable. And obviously that will have a psychological impact, an exclusive impact in that regard. I'm very passionate about women's health, women's gynecological health. And as you know, and most people who would be here, it's one that is very lacking in research. 1 to 2% is what they quote as the funding that's given to women's health research. And that's if we exclude cancer. And as soon as we add intersectionalities, including ethnicity, and also going down the route of those who are neurodivergent or neurodiverse, those with learning disabilities, learning difficulties, or disabled individuals in general. We talk about the LGBTQ community and so on. It's even wider. So that's something that needs to change. And it is why I'm really passionate about all the education and awareness that I do, because it not only will change and positively impact lives, it will save lives.
Thank you very much. And is it something that do you see problems on the front line of healthcare relating to inequity in health research as well? Is it something that you see as a GP?
Yeah, of course. So if we speak specifically about women's health as an example, I have many patients who, for instance, have fibroids or even endometriosis. Okay, and we know that conditions like fibroids affect Black women disproportionately. We're 2 to 3 times more likely to have fibroids, and even then, we are more likely to have worsened symptoms and more likely to be offered treatment, radical treatment like hysterectomies and so on. And that has long-term complications. Yet we still don't understand why it happens, why it affects Black women more, and also how to cure it. If you don't know why, how are you going to cure it? Do you understand what I'm saying? And it's the same with endometriosis. So I am having a lot of patients who come to me desperately looking for treatment and suffering, often in silence. So I usually carry this around, and I'm going to show it to everyone in this talk. So do you know what this is, Anna?
It's a vulva, I believe.
Yes. It is a vulva, it's not a vagina. And I often get, if this was live in person, I would have gotten everyone to say the word vulva, because it's not a bad word. And actually, it's to destigmatize women's health, because there's a lot of shame, there's a lot of taboo, embarrassment. And I often say there are people who are dying of embarrassment because they don't come forward about these symptoms because they're too embarrassed to come forward about them. And also, it's the fact that a lot of people are not aware of what symptoms are normal versus abnormal. And if we talk something simple as periods, having heavy, painful periods, that's not normal, but that's been normalized as a plight that women just have to go through, or those who menstruate. So yes, in answer to your question, this is something I see a lot in the front line, and something that 100% needs to change. And it can only change if we admit that these problems exist, and we don't shy away from the fact that systemic racism is real and it has an impact on the research being covered. And if I go as far as sickle cell anemia, and if we look at the research that's done in sickle cell, though it was found to be a hereditary condition, I think in the 50s, and if we compare it to, and I want to just preface this because I don't want people to think, oh, we shouldn't give treatment to other conditions. 100% we need to give treatment to all the conditions. But if we compare it to a condition that is comparable to sickle cell disease in terms of how it's inherited, so autosomal recessive, in that you need at least one faulty gene from either parent, sickle cell anemia versus cystic fibrosis, if we look at the fact that sickle cell anemia was found to be a hereditary disease earlier on than cystic fibrosis, yet there are, I believe, 500 treatments for cystic fibrosis versus 3 for sickle cell, and the condition sickle cell affects in the UK, I believe 18,000, and I believe it's around 11,000 for cystic fibrosis. And the only main difference between the two conditions is who it affects predominantly. So sickle cell disease predominantly affects Black people, whereas cystic fibrosis predominantly affects white people. And the disparity in the amount of research that's being done in cystic fibrosis versus sickle cell is mind-blowing. And that just confirms the fact that, unfortunately, just having a different ethnicity puts you at a disadvantage.
Absolutely, yeah, it's shocking statistics that. And in terms of sort of broader pieces of research that look at disease areas that maybe are a bit more equal in terms of sort of how they affect people from different ethnicities, or that are just sort of bigger health research problems generally. I think there's still a problem with people from Black and Asian and lower income backgrounds being underrepresented as participants in those studies as well. I mean, what can we do about that? Do you think there's work we can be doing there as well?
Absolutely. I mean, there are a multitude of reasons for that. And if we go as simple as first health literacy, there is sometimes in people of lower socioeconomic backgrounds, they don't have that health literacy, and often they don't know that they don't have it. So there's that thing of you don't know what you don't know. And again, this is why I'm a big advocate for health education, health promotion across the population. But if we go as deep as the fact that there's no trust within healthcare, and this can be due to the lack of representation. So having people forward facing, so having people, for instance, like me and other doctors who are of similar ethnicity, that helps to build a little bit of trust within the communities. Trust was broken over the years. We talk about the Tuskegee trial in the US, where unfortunately they did the research on Black men and they gave them false information, and they went as far as not treating them when treatment was available for over 20 years just to see how syphilis long term, what the complications are. Terrible. That was that went on for, I believe, for 40 years between the 30s to the 70s, and it was only because someone whistleblowed. Otherwise, it would have continued. But if we go not even that far, as recent as 2020, when two French doctors stated publicly in an interview, worldwide interview, oh, we should test the COVID vaccine on the Black population, just like we did for AIDS, where they tested the treatment on prostitutes, because these lives are dispendable, essentially. That is what makes these populations not trust researchers, and they don't come forward, and that adds to the underrepresentation. But also there's not enough research funding for those populations. So if you do have people who are interested or who want to get involved, there's just not enough funding or research available within that platform. So it's something that needs to change, because we know that at the moment majority of research is done on, able-bodied, Eurocentric men who are of a certain weight. And that disadvantages a whole lot of the population, because it's extremely exclusive and it's not one size fits all.
Yeah, absolutely. So yeah, there's sort of lots of different angles we need to sort of approach this from, isn't there, in terms of the type of studies it is, but also those trust issues. And I think the trust issue is something that certainly in our work we've seen come up sort of time and time again. I mean, but where do we need to start in terms of addressing that? How do we rebuild that trust when it's being so sort of fundamentally damaged?
Of course, you go to the population, you go to the individuals, and you listen to them, and you believe them, and you have them as part of the research and the service provision that you're making. I think often what happens is that people create all these campaigns and research projects, without including the people who are they're supposed to be researching. There are loads of community advocacy groups, there are loads of grassroots organizations which should be included at the very early stages to get the advice. And also these community groups and organizations have the trust of their community. So definitely have them involved. But also in terms of trust, we always say that change happens at the speed of trust. So the moment that you have the trust that is consistent and for the right reasons, it could make that difference. It could, generate and build the possibility for more and more individuals within those communities to be researched. And there's one more thing I was going to say in terms of grassroots organization and research. It's the funding, because a lot of these grassroots organizations do it voluntarily with their own funding and their own money. And it's just a backward thing, because how can they progress and move forward if they don't have the money? So just generating income and funding within those communities can make the massive difference.
Absolutely. That's been fascinating. Thank you very much for talking to me today. I think we could sort of carry on talking for ages. So I think you're joining us again later on for the panel discussion. So hopefully we can chat a little bit more then. But now we're going to actually move on to our first presentation of the morning. So I'm going to welcome back Laura King, who is the Director of External Affairs at GRAIL, and also Claremont MD Ian Fannin, who are going to be talking to us about the NHS Gallery trial, which, as I mentioned earlier, this recruited over 140,000 participants from proportionally representative backgrounds in just over 10 and a half months. So I will now over to Laura and Ian. Thank you very much.
Thank you, Anna. So yes, Ian and I are here today to talk about how we recruited a socio-demographically diverse population to the NHS Gallery trial. Next slide, please, Ian. So I need to show the slide for regulatory and compliance purposes, but just to be clear, I do work for Grail, which is the company that developed the test, which is under investigation in the NHS Gallery trial. And this test is currently only available in the UK through the trial. Next slide, please. So the NHS Gallery trial is investigating a blood test to see if it can help the NHS to detect cancer early when used alongside existing NHS cancer screening programmes. So cancer screening looks for cancer in people who have no symptoms in the aim of finding it early when it is usually easier to treat. In the UK, we currently screen for 4 cancer types: breast, cervical, colorectal, and more recently lung cancer in high-risk groups. The hope is that by using the test alongside these existing cancer screening programmes, we may be able to find many more different types of cancer earlier than they otherwise would have been found. And this is essentially what the NHS Gallery trial is trying to investigate. Over 140,000 people have registered to take part, and we are close to further registration at this time, with results expected in 2026, which is just next year. Next slide, please. But if you cast your minds back to 2021, which is when we were finalising our recruitment plans for the NHS Gallery trial, there are a few things we knew we needed to achieve. We wanted to enrol over 140,000 participants in less than a year across 8 participating cancer alliances, and these are shown in dark purple on the map on the left-hand side. We also wanted to achieve as representative a cohort as possible the intended use population. So this is people aged 50 to 77 living in the UK across the ethnic groups and socio-economic groups. And as you heard earlier, it's usually older, minority ethnic and more socio-economically deprived individuals that tend to be less well represented in research. And that was a trend we were very keen not to follow. We also knew at the time that we would be using a centralised invitation process. This means invitations were sent by NHS DigiTrials using health service records and other nationally available datasets to help us prioritise sending individual invitations to areas of greater socioeconomic deprivation and greater ethnic diversity, so being able to target individuals in the first instance. But when we think about how the trial is designed, there's a few things that are quite complicated to explain that might form challenges or barriers to people being able to accept that invitation. Next slide, please. So in the NHS Gallery trial, when participants first took part, they gave a blood sample and were randomised 1-to-1 into either the test or control arms of the trial. And this was done blinded, which means people do not know which group they are in. If they were assigned to the control group, their samples are stored and might be tested in the future, but they will not receive any results. If they end up in the test group, their samples are shipped to Grail in the US for testing, and only if a cancer signal is detected are they told of the result, and this is because they need to be referred to the NHS for further testing to confirm if cancer is present. In both the test and control arms, if cancer is not diagnosed in the interim period, participants are invited to return for annual appointments. So you can see that with this design process, the only people in the trial who receive a test result and know which group they're in are those in the test group that have a cancer signal detected. Everyone else remains blinded. And this blinding is really important to the trial integrity. For example, if somebody knows that they are in the test group, it might change their health behaviour. They might think, oh, I've been screened for cancer, I don't need to worry about this symptom and go to my GP. That's absolutely not what we want to happen. We want people to maintain their normal health behaviour, continue to seek standard of care so that we can be really sure that by having the test has made this difference in being able to find more cancers early. But when you look at this process, it is quite complicated to explain. Also, if you take part, you need to be aware that you might end up with a cancer diagnosis when you're otherwise feeling healthy and normal. If you are motivated by the idea of having the test, there's actually no guarantee of receiving that test. And you will only be told if you have a cancer signal detected result, and you need to be happy with your samples being shipped abroad to the US. But it's really important that we went to the communities themselves to understand how they interpreted this information and how we could best support them to make an informed decision about whether or not they wanted to take part. And that's where we invited Claremont to help us.
Thanks, Laura. So yeah, we were brought in right at the beginning of the trial in early 2021, and we planned our research in 2 phases. So the first phase was to do separate PPI groups with Black, South Asian and white members of the public in the eligible age group, with our sample overall skewed towards lower socioeconomic groups as well. And that was also then followed by interviews that were conducted by academics at the Cancer Prevention Trials Unit. And the aim was to understand attitudes towards the test and the trial, motivations and perceptions of risk associated with taking part, and to use these insights to inform recruitment, retention and engagement strategies. And then the second phase of the research was also with the public, but also then with leaders at the participating cancer alliances to try and test naming options for the trial and develop messaging and framing for trial communications. And I won't dwell on every insight from the research. There was a slide deck that was about 50 slides long that went through in great detail what we learned from that research, but I will try and pick out a few key points that directed our strategy. So, for example, our research showed that motivation to participate was really high because the test was seen as a valuable and exciting innovation, but this motivation could reduce for some under closer scrutiny of what was involved. And in particular, we saw fear and anxiety associated with cancer tests, particularly related to what would happen in the event of a cancer signal being detected. And that's not surprising. In general, we know people dislike uncertainty. And we were doing this research in the immediate aftermath of the pandemic, and awareness of NHS pressures was high. So people needed reassurance that if something was detected, they would be seen to quickly. So we needed to be really explicit in our communications about the referral pathway and the priority the NHS would give to such referrals. But more than that, we also saw that NHS involvement added real trust and credibility, and people wanted to help the NHS to save lives. So this underlined the critical importance of ensuring the NHS's role in supporting the trial was prominent in branding and messaging, hence the NHS Gallery trial name. It was clear from our groups, and Dr. Sese referred to this, that the challenges with low health literacy. I think I'd take that on a step as well and say there's low science literacy in general in the general population, and that was particularly so amongst some of the underrepresented groups we wanted to engage, and so people found it hard to understand elements of the trial design, especially the role and value of the control group that Laura was referring to. So we needed to ensure that participant content explained the why, not just the what, behind how the trial would operate, to minimise the risk of participants perceiving being randomised to the control group as an inferior outcome, which could impact retention. And we noticed that issues of trust were greater among Black respondents. Anna and Dr. Sese were just referring to that, and that was especially around DNA storage in relation to this trial, and we found that that could suppress motivation to participate in those groups. And from the research we did, we concluded that information alone would not be enough to resolve that, and that really meaningful community engagement through trusted influencers and networks was key. And then overall, maintaining motivation among participants in spite of the anxieties that I've described appeared to rely on sustaining that strong altruistic intent throughout the trial. So it was important for us to make sure we plan ways to regularly thank participants for their contribution to the trial and to make them feel part of an amazing collective endeavour. So we used those insights to test a range of messages, which led to developing a message framework, which articulated the why, who, what and how of the trial. And we had an overarching proposition, which was let's detect cancer early. And we worked hard to ensure that this proposition and those key messages came through strongly in every communications channel and every participant interaction. So, for example, in the adverts and posters seen on the left here, on the website and on other trial materials, and even on the side of the mobile clinics. And we produced 2 animated films, one for the website and one to be shown in the mobile units as part of the consenting process. And we used animation in particular to help explain some of the elements of the trial design that were harder for people to grasp using written word alone. So, for example, the concept of the control group. And visually too, we chose warm, restrained colours and simple, uncluttered designs, which was even applied to the interior of the units. And this was important to maximise reassurance to act on our insight around cancer-causing anxiety, which we felt would contribute to ensuring a positive participant experience, to support retention and ensure people would feel good about being asked to come back the following year. Back to you, Laura.
Thanks, Ian. So we used Claremont's insights to develop these optimised participant materials, and just to add, that also included translated materials to help those that had certain language requirements. We also used Claremont's support on our national communication campaign to secure coverage in press, radio and television outlets. And this really helped create a general national awareness and buzz around the trial, particularly when those mobile clinics were first arriving on site. We also worked with community leaders for community engagement activities. So this ranged from the distribution of leaflets by local champions, local ambassadors recording videos for social media. One thing I would highlight is because we were doing this recruitment phase during the pandemic, there's probably more digital solutions that we had to use as opposed to standard printed press posters and that sort of thing. So in particular, I remember here WhatsApp channels and those community groups being really important to make sure we had messaging and images which they could use on WhatsApp. Another really important thing was considering the operational decisions we could make to help reduce barriers to participation. So I mentioned earlier there the mobile clinics. We had large mobile clinics and lightweight vans which could go and place the trial in the heart of communities, making it as easy as possible for people to take part. We worked very closely with the Cancer Alliances to plan where those mobile clinics should go and make sure there were some good transport links for those. We also developed things like on-demand interpreter services, ensured there was step-free access and hearing assistance, all things to make sure we could accommodate people's needs to make it as easy as possible for them to take part in the trial. Next slide, please. So how did we do? This slide gives an idea of how we performed in terms of age, deprivation and ethnicity. In the dark purple is how the trial performed. In light blue is England national levels, and in the grey is at the Cancer Alliance regional level. And what you can see is the trial is very well represented for older and more deprived individuals. Where I performed well in representation of Black and Asian participants, we could have done better, and I think that's really important to acknowledge. Next slide, please. I particularly like the information on this slide because it tells us just how many people we need to invite with that targeted invitation process in order to achieve a single enrolment. And what you can see is we need to invite many more younger, male, more deprived and Black and Asian individuals to achieve an enrolment. And I think this is really important information to see. It suggests that there is still more that needs to be done to support these individuals and communities to take part in research. And just having the targeted invitation process isn't good enough alone. We need to still be working on those mechanisms to support people to feel comfortable to take up that research invitation. Next slide, please. So in terms of my lessons from the recruitment phase of the trial, I think firstly, know your audience, knowing their motivations and barriers, speaking to them directly so you can develop materials and resources to best help them and manage their concerns. But this doesn't just mean upfront focus groups. I think one thing we did very well in the trial was constantly using surveys to obtain feedback from our participants. Your participants are the greatest critics to help you improve your trial as you go along. Also, the power of data to really understand the demographics you're trying to reach, to plan your recruitment activities and monitor your cohort as it grows. Planning ahead. In particular here, I'm thinking of our community engagement activities. As you heard earlier, these are often run on a voluntary basis. They're busy people. Make it easy for them to work with you by engaging early with clear and simple requests. And finally, an innovative and adaptive mindset. I think this was particularly important in a trial like the NHS Gallery trial, which is working at such pace. We need to embrace diverse opinions, challenge the status quo, and work at pace to deliver those changes. Because the one thing we know is that how things were currently done isn't good enough to reach these diverse groups, and we need to be doing better. Thank you.
That's great. Thank you very much, Laura and Ian. That was really interesting to hear all the work you've been doing there. So if anybody has any questions that they would like to ask Laura or Ian or any of our other speakers as well, please do post them in the Q&A and we'll either come back to those during the panel discussion or they will reply directly in the Q&A. So next up, we are going to be hearing from Annika Ladver and Kirsten Purvis, who are both from Our Future Health. Annika is the Head of Community Engagement and Kirsten is the Head of Experimentation and Insights. And they're going to be talking to us about the learnings from the world's largest medical research programme. So over to you, Annika and Kirsten. Thank you.
Great, thanks, Anna. Hi, everyone. As Anna mentioned, Kirsten and myself will be sharing some learnings from Our Future Health when it comes to recruiting people from underrepresented communities. So hopefully many of you have heard of Our Future Health, but I will run through a really quick overview for those who are less familiar. So we are the UK's largest health research programme, and we're aiming to recruit 5 million volunteers, which is about 1 in 10 of the adult population in the UK, to build one of the most detailed pictures we've ever had of our nation's health. So Our Future Health is very much designed to help people live healthier lives for longer. So by spotting patterns and signs of disease earlier, we can develop more effective ways to prevent, detect and treat diseases. And we're very much doing this in partnership with others, so from the NHS to community organisations to researchers. A really quick run through in terms of what our recruitment pathway looks like. So we are working in partnership with the NHS to send invitation letters to individuals over the age of 18 who live near one of our clinics, and eventually everybody in the UK will receive one of these invite letters. But essentially, when someone receives their invite and clicks through to our website, they can then register with us. They're then given a lot of information about what's involved in terms of taking part, and they're taken through the consent process. And then in order to become a full participant, they need to complete a health questionnaire, which covers any conditions they have, lifestyle factors, family history, etc. And then participants will also need to attend an appointment with their local clinic where they will have physical measurements and a blood sample taken. And then when giving consent, participants also agree to access their health records and recontact for further relevant recontact studies. So as of this week, this is currently the number of people that is taking part, which is absolutely incredible. But as the UK's largest research programme, we need a diverse range of people from all backgrounds and communities to be part of our Future Health so that it truly reflects the whole population. So the more communities that join our Future Health, the more discoveries that we can make for everyone. So with over 2 million participants consented and over 1 million full participants, which includes around 10% from ethnic minorities and underserved communities, our commitment to growing diversity remains central to our mission. But we know that this is a hard space. So we know that certain communities are less trusting when it comes to health research and data, which has been spoken about already today. We know that different communities have different perceptions and different barriers. And we also know that when it comes to these barriers, that can range from time to education and understanding, accessibility, the list goes on. So with that being said, we are committed to very much taking a test and learn approach at our Future Health to really understand what can work for these groups and communities that we're trying to reach. So today we'll be taking you through some areas that we've explored and what we've learned so far. So we will be kicking off with engagement and what we've learned by building awareness and trust and deepening relationships within specific communities. We'll then share some learnings on how we've tried to make joining our Future Health more equitable. And then finally, we'll be sharing some initial learnings on a live feasibility pilot, which we hope will give people more of an opportunity to join the programme. And that, just to sort of say that there's a lot more work to be done in this space, but in terms of what we've sort of seen so far in terms of impact and results, we hope that we're moving in the right direction. So I'll hand over to Kirsten now, who's going to talk through the first two areas.
Hello, yes, thank you, Annika, and thank you so much for inviting us to this really great event. Just, I guess, to flag that this is a really short period of time to cover a lot of work that has been done over a lot of years by a lot of people. So we're really going to try and draw out just a couple of top-level learnings and smash a lot of things into a few slides. Please do pop questions into the Q&A if you want any details as we go through. So on the topic of engagement, we've spoken about it a lot already today and in this presentation, but we know that skepticism and trust can be barriers to taking part in health research. In some work that was actually carried out in partnership with Claremont many years ago, it was a series of interviews and focus groups. We really found that people from ethnic minority backgrounds and those on lower incomes have lower than average trust in science research. Taboos around talking about illness might exist in some communities, and there have been historic violations of trust between medical researchers and communities that continue to negatively impact trust today. We've also seen, and the desk research Claremont carried out really, held up, that studies that take the time to build genuine targeted partnerships with communities are more successful at recruiting diversely. Sorry, Annika, if we can move on to the next slide. Thank you. I realized that I was skipping ahead on my own and wasn't thinking. So with all of that in mind, I think we can quite safely say that what works cost efficiently at scale isn't going to overcome these barriers where they exist. You can imagine if you receive one of our invitation letters on your doorstep and you're this top person with a library full of life experiences, which has filled you with good expectations and reasons to trust health researchers and the NHS and health research. And perhaps communities who are really supportive of those initiatives, you know, receiving a letter might immediately engender a positive response. You have a lot of intrinsic motivation and you might join. Receiving a letter if you've got a sort of mental library of experiences which have led you to distrust. Maybe you've got experience and knowledge of systemic biases and failures in the system. You have bad experiences or expectations, and communities who may have, you know, rightfully so, much more distrust and skepticism. You know, receiving a letter probably isn't enough to engender that intrinsic motivation to join a study. But we thought there might be ways of really capitalizing on sort of building trust and putting effort into community engagement to kind of blend this recruitment at scale with community engagement and building. And we performed a series of pilots, which found that actually community engagement does increase the likelihood of taking part when you're invited further down the line. So in areas like on the left one, my little illustration there, where we had a convenient community clinic location where people could do their appointment and provide their blood samples. And we had community targeted letters that we sent to invite people to that location. We saw some uptake. But in areas which we'd matched sociodemographically and for the same sort of time and approach, where we actually went in ahead of time and we formed partnerships and relationships with community leaders. We capitalized on social media, both our own and that of organizations. We built a community presence. We put graffiti in areas, billboards, sought local business support, also had a community clinic location, and really there to answer questions, speak about the program, and build that trust and earn that trust. When we send letters there, we saw a significantly higher uptake to those invitations. So I like to think that it's sort of adding a few more books to that mental library. Really, the effect that we saw amounted to an extra 15 people for every 1,000 we invite, and most of those from the youngest age groups and people from ethnic minority groups in these trials. So that was a real fast whistle stop, but I guess just showing that, you know, when we apply what we know about building trust, it really works. I'm now going to move on to the question of equity, so maximizing inclusivity in our program. So Our Future Health is committed to the principle of equity and participation and widening access as substantially as possible. And we thought one possible way to achieve this is offering reimbursement, which compensates people for the time and cost of participating in our studies. And really the aim of it is to reduce practical barriers to participation for groups who might otherwise struggle, even when given the opportunity. Of course, at the scale we're recruiting at, it's really important that we tested this well. We needed to make sure it was scalable and we could roll it out in a viable and ethical way to, you know, increase rates of participation in groups who are underrepresented in our cohort. I'm not going to take you through the full trial, but overall, we saw that reimbursement had a positive effect on participation. So what you're looking at here is a bar plot showing something called the marginal effects of reimbursements. And really it's just a way of presenting differences in probabilities. So the bar on the very right-hand side, the green is the people or the probability of people in a reimbursement condition becoming full participants of the program. And the blue is the probability of people in the control condition becoming full participants of the program. We can see that when we offer reimbursement, we expect 24% more people to become full participants in the program. But really interestingly and importantly, this uplift was greater for those who are younger, which is the bar plot sets on the left, who are more socioeconomically deprived, which is the set of bar plots in the middle, and who are more ethnically diverse, which is the set of bar plots on the right. So basically we could see that across the board, reimbursement makes it more likely that people will join the program, but it makes it particularly more likely that groups who are currently underrepresented in our cohorts and in research in general are able to join and overcome those barriers. So when we fully rolled out reimbursement to the cohort, we continue to see a positive effect. Program consent rates have increased since we rolled it out. The percentage of the cohort who are younger, more deprived, and from minority ethnicity groups has increased. And our rates of starting and completing questionnaires, which is a really important part of the kind of scientific value of this cohort, has increased, which is illustrated in the table below. And with that, I'll hand back to Annika to talk to you about the last of our strands.
Great, thank you. I'm conscious of time, so I'm going to whiz through the final few slides. So as you can see, we've done work to engage with communities to make the process more equitable. But when we were doing that, we gained sort of further insight on how we could reduce barriers for groups and communities. So one of the things that we did is we ran a survey with participants that had signed up and consented to Our Future Health, but had not yet booked a clinic appointment. So to understand, what we wanted to do was understand whether they intended to book one, and if not, what were the barriers they were facing. So, oh, sorry, I skipped ahead to, sorry, yes. So what we sort of saw with that is that people did intend to book an appointment or wanted to book an appointment, but 56% of the yes group were from ethnic minority groups. So then when we looked into what the barriers were, the physical opportunity was the most significant barrier. So when we then explored some solutions to help understand the barriers in attending, that is when a walk-in clinic emerged as an option, which you can see on the far right. So we know now that pre-booking is a barrier to participation for people from underrepresented backgrounds. And what we're now doing is developing a new enrollment journey that allows people to join the program without needing to pre-book an appointment. So we anticipate that this method of recruitment will not only remove some of these barriers, but also enable a more agile and versatile approach to recruitment within a wider range of settings. So the pilot that we are currently doing is very much a feasibility pilot, and we're looking at the effectiveness of walk-ins in terms of ethical, operational, and technical elements. It's also going to help us gather data and insights to inform future iterations and scalability of the initiative. So there are a number of things that we need to learn if we are to roll it out wider, as this is very, very new to us. So at this stage, we want to understand things like, is it feasible in terms of a product build? Do people like this journey? Did they find it convenient? Would people not have attended a clinic appointment if it wasn't for the walk-in opportunity? The other thing that I wanted to call out at this stage is that we're very aware that people are making a decision on the spot when it comes to a walk-in clinic, and they might not be taking everything on board. So we are going to be actively monitoring this, withdrawals, etc. But what the next stage would look like if the feasibility pilot is successful is looking to compare this model to a regular recruitment route. So far, we've delivered 12 days of walk-in clinics across 4 different locations, and that's been at a mix of diverse community settings or large-scale events aimed at specific communities. We have another 2 months left of this pilot, but in terms of initial learnings and observations, the first thing that we can see is that the walk-in model is providing opportunities for communities to join the program if we bring the clinic to them. And as you can see from the table and the ethnic minority column, it's really promising. The second point is that people were really interested to take part after we engaged with them. I think what some people may find off-putting is sort of the process and doing that in isolation, but actually we had people on the ground. They were talking to people about the process, why we're doing what we're doing, and that really helped with engagement and understanding. And what we also found was, regardless of it being absolutely freezing outside, people were willing to wait up to 30 to 60 minutes to take part of the process, which was really incredible to see. And the other thing that we also noticed was that at 3 of the locations, at least 50% of those that had their clinic appointment submitted their questionnaire soon after, converting them to full participants, which was amazing. We actually saw a lot of people filling out their questionnaire there and then because they wanted support in case they had further questions. The final thing just to say on walk-in is that it's very much helping us reach people that we wouldn't have been able to reach otherwise. So on the left-hand side, we can now sort of see that many people that were recruited via the walk-in route said they were less likely to have joined if the walk-in clinic had not been there. And then just on a general, more positive note, the overall experience has been positive and enjoyable for a majority of the participants, which is great. So to very, very quickly summarize a few things that we've learned so far. One is creating awareness, sharing information and answering questions and demonstrating trustworthiness is important. Having a multi-layered approach to engaging and recruiting members of underrepresented communities helps overcome different barriers that they may experience. And then finally, when we remove practical barriers to participation, we enable people from more younger, more socioeconomically deprived and ethnic minority backgrounds to join the programme. So the final thing I will say before I wrap up is that we, as well as the walk-in pilot, we're also exploring and launching some really exciting projects this year. So that includes a community champions program and also looking to do more community partnerships. So there will be some really great learnings that come out of all of these three areas this calendar year. So definitely watch this space.
That's great. Thank you very much, Annika and Kirsten. That was really interesting, and we look forward to hearing more about your plans as they continue as well. So thank you. So if anyone has any more questions, please do put them in the Q&A. I can see some great questions being put in there already. I'm now going to hand over to Tim Parry, who's one of the directors at Claremont, and Byron Tibbetts, who is head of programs at Akrivia Health, for our final presentation of the morning. So Tim and Byron will be talking about the work that they've been doing together to recruit a large cohort of people with severe mental health problems to the Global Mind study. Thank you very much.
Thank you, Anna. I can only see my colleague Byron on screen, so I just get a check that my slides are visible, please? I'm getting a thumbs up, so it looks like we're good to go. Yeah, so thanks, Anna. And it's been really inspiring to hear from Grail and from Our Future Health this morning about the sort of level of depth and comprehensive approach that those programs are taking. Lots for us to learn on the program that we'll be talking about. We're a bit earlier on in the process, so it's quite exciting to tell you a bit more about our ambition and the foundations we've put in place for the work we've been doing together with Akrivia. But Byron, let's start with you, and if you can give us a bit of context, perhaps about Akrivia first, and then we can talk about Global Minds more specifically.
Super, thanks, Tim. Wonderful. Well, I suppose in terms of introducing Akrivia, what if severe mental health conditions were treatable in the same way that many physical conditions are, with targeted treatments that work on causal pathways rather than just managing symptoms? What if, by leveraging data-driven insights, we could reclassify mental health conditions based on how they present, not just symptomologically, but biologically as well, to better target drug discovery towards precision medicine approaches? That's I suppose, a bit of a cheesy way to introduce who Akrivia are, but we're a data science company operating commercially now, but we started out as a technical project first in an NHS organization and then later at Oxford University, where we span out from in 2019. And our mission is to change the trajectory of research in mental health and neuroscience by improving both the quality and the availability, crucially, of data held on mental health conditions and the people who experience them. We do this basically by collating, harmonizing and structuring electronic medical record data from NHS mental health trusts, using proprietary natural language processing models that we've developed to derive structured data points from the rich, free text clinical notes that are the mainstay data type in these records. Our work enables the NHS organizations that we're partnered with, as well as academic and commercial clients and collaborators, to better conduct things like safety audits, explore the effectiveness of treatment pathways, find and recruit patients to trials, and generally conduct research with the aim of understanding mental health conditions better. And we know that our work with electronic medical records is going to revolutionize how some of the most challenging mental health conditions can be profiled and potentially understood. And we're already developing predictive tools using our data set that could improve early detection of treatment resistance in some disease areas, for instance. As we move on to think about Global Minds, Global Minds is the extension of our mission beyond simply working with electronic medical records. Global Minds sees us working to augment these enriched EMRs with biological endpoints like polygenic risk scores, genetic variants, biomarkers, to turn our two-dimensional profiling of disease signatures into a three-dimensional disease signature profile. And from there, we can use that data set to identify biological targets for drug discovery, move towards a precision medicine approach that has not been achievable in mental health to date. Global Minds is the clinical study sponsored by Acrivia and co-funded by the Wellcome Trust, the purpose of which is to recruit and collect data and biological samples from a diverse and representative cohort comprising 50,000 people living with these conditions. And we'll pair the data from Global Minds, the study, with the electronic medical record data that we already curate on behalf of the NHS Trust in our network to make that 3D data set. Now, we know that access to care and research does differ by ethnicity and socioeconomic status. And we also know that genetic ancestry does factor in some psychiatric conditions. So recruitment of a representative cohort of this many vulnerable individuals whose medical records we can access is our first and most pressing challenge, and what brought us to Claremont, and we're working out the best way to approach it. We benefit from the lessons like those coming out of OFH and NHS Gallery that we've just heard about, but it's also true that our population is distinct from either of those, and so some considerations are unique to Global Minds. We knew that the approach we took to address inclusive engagement in Global Minds needed to be led by potential participants, and so that's where we started together. Tim is going to take you through some of our initial work that we did that helped to inform our study elements and approach.
Yeah, thanks, Byron. And I think people are going to be in this webinar, they're going to be operating at lots of different budget points. We know that, and we've seen some incredibly comprehensive approaches. But I think I'd come back to Dr. Sesay's point up front, which was the principle of spending time with the audiences you're trying to reach, regardless of budget. That should be something we should all strive to do. And I think, speaking personally from earlier in my career, having tried to develop campaigns and interventions many years ago, where you get excited by your own idea and wade in there, and they have not been anywhere near as successful as more latter day efforts that I've been part of. With I was formerly at Alzheimer's Research UK, and certainly in projects at Claremont, when you spend time and listen carefully to the audience that you're trying to reach and whose lives you're trying to impact. So we are at an earlier stage with Global Minds than we've heard from Graham and Our Future Health. So I'm just going to focus a little bit on a very early stage piece of work that we've done with Acrivia, the foundational work, which is very much focused on spending time with that audience. And the purpose of doing this really is to build solid foundations for Global Minds as soon as you start to formulate what the communications and even what the program itself might look like. So when we set off on this piece of work, the 3 points on screen, what we were really trying to address, to fundamentally understand how participants or would-be participants feel about Global Minds as a program, what might help them to take part and what might hold them back, and then the beginnings of how we begin to communicate about Global Minds. Make its complexity simple, make it relatable and easy to understand. And this is how we went about doing that process. We started with desk research, so a literature review. We looked at comparable studies in academic literature from around the world. Nothing is exactly the same as Global Minds, it's unique, but there were other cohort type studies and even clinical trials up to a point in the mental health space that give us lots of learnings about what can enable participation and what are the kind of bear traps that hold people back. So we had a good look at everything in the literature, and from that we built out a behavioural hypotheses, and we use the COM-B model, which I'm sure a lot of people on this call will have heard of. It's on screen. It's a model that encourages us to consider the capabilities of the audience that we're trying to reach, the opportunities that they will need to undertake that behaviour, and what might motivate them to do that. It really structures your thinking about how you design your interventional campaign to reach that audience, and encourages you to break down all these different considerations. When we built that COM-B model, which I'll show you in a second, we then took those hypotheses from the literature and from the experience of colleagues at Acrivia and our own experience, and then we worked those through those depth interviews with people living with the mental health conditions that we're interested in, to see how they played out and to further refine them, ready to build strategies to undertake the development of our campaign work. So as we've heard in other presentations, there are reams of information, a full report that we produced at the end of this process. We haven't got time to go into that right now, but I thought I'd pick out a few of the kind of barriers, if you like, that we identified in the COM-B analysis, and then some of the opportunities for resolving those. In terms of capability, some of these are kind of egg-sucking points, but it's easy to miss the obvious. But you know, scientific levels of public understanding of scientific studies in general are not always great. So the fundamental principle of making your project, your program, your trial easy to understand is absolutely crucial. So make sure that people understand what you're trying to do. In terms of physical capabilities, we heard a lot of this from Our Future Health a moment ago, but you know, consider the cost and distance and inconvenience of your participants, and how you can make that easier for them. That's something we looked at. In terms of the opportunity for people to take part, as Byron said, we're working very specifically in the mental health space, and we know there are sensitivities and stigmas and potentially cultural and religious considerations in this area, and that's something that we want to make sure that we explored throughout our interviews with would-be participants. Site accessibility kind of goes with that cost and distance point. And in terms of motivation, we found some interesting insights from the literature around how whether study or trial or program participation might compromise people's immigration status, you know, put a spotlight on them in a way that they may not want. So it's something to be sensitive about. And this is very data focused. Global Minds is very data focused. So we should always be cognizant of privacy concerns and ensuring people understand how we're using their data, and particularly any biological samples, but particularly in the mental health space, privacy concerns are important. And also, and this does apply to Acrivia, who are lesser known brand, particularly in the patient-facing space. You know, how do we build and how do we understand the importance of trust in the team that are actually running the program itself? That's something that's particularly important for Global Minds. So the flip side of those challenges are, you know, what do we, you know, how do we resolve those things? What might be the solutions? And these are all hypotheses. These are considerations we felt would be important that we then test out through our depth interviews. So clear, simple communication speaks for itself. We've heard a bit about financial reimbursement, some really interesting data from Our Future Health there. So reimbursement is a part of Global Minds, but how do you frame that? How high up the order of communication does that come? How much of a motivator is that? That needs to be thought about carefully and explored. And one of the unique elements of Global Minds as well is rather than requiring people to travel, their model brilliantly allows the study team to come to participants, particularly if they are giving blood samples into the study. So, you know, how do we best present that and make that easy and comfortable for participants to understand? In terms of the opportunity elements of the model, we've heard this again from everyone this morning, but the importance of building relationships, genuine, authentic relationships with communities and cultural leaders. This is very much on our agenda for the next few months, and we're looking at two very specific areas to do that. We're under no illusions that we can wade into areas and, you know, expect communities to you know, to jump at this opportunity. It needs to be handled sensitively and communicated effectively and authentically. We talked about motivations already, but, you know, just be cognizant of any kind of cultural norms around giving and how incentives works and gifting. That's something to be aware of. And we've already mentioned cultural leaders, so I'll move this on. This is a horrifying slide, and you're not under any obligation to take all this in, but I put this up on screen to make the point that something we're really keen about when we spend time with audiences is to try and think in as nuanced and detailed a way as we possibly can about how we segment that audience. And I think, you know, years ago, we would typically just say, right, well, we want general public, which isn't an audience at all. Or we might just think of very simple binaries like, you know, kind of gender or you know, different ethnicities and age. All those things are important, but I put this up on screen to illustrate all the different attitudes, behavioral and psychographic attitudes, as well as demographics that we considered in terms of building our group of representative participants to do our research with. So it was too simple just to go with pure demographic elements. And I will just plug as well that we use an online platform that people today might want to explore called Prolific. If you don't already know it, it facilitates research with people really effectively and cost effectively. It allows you to move quickly, and feasibility check as well in terms of who you're trying to reach. So that's a great platform. And we use Calendly as well to allow participants in our interviews to book their own times and make it easy and make research easy to perform. So we did do 20 depth interviews. Here's just a quick headline snapshot of who we spoke to, a mix of the three different mental health conditions that Global Minds is focusing on, a good mix of age ranges and gender and ethnicity as well, which was remiss of me not to put on this slide, but we're very happy about the sort of representative nature of the interviews that we did. This slide has got a really funky build for some reason. I'm just going to bring them all up on screen. So here are just a few principles that we've taken away. Again, there are many more headlines from this after our interviews with would-be participants, but just a few things to share with the meeting today. And as we've heard elsewhere this morning, but I think this is particularly true in the mental health space, and I've seen this in the cognitive health space as well in my time at Alzheimer's Research UK, that there is clear altruism for these kind of studies, for this kind of research. People who are living with mental health conditions or with neurodegeneration, they understand that the treatments and diagnoses and options have been limited for a very long time. So there's a great sense of will and desire for people to join into research that might offer better options for people like them. So it's really great to see that. We've got to take that goodwill seriously and do right by that. We've spoken a bit about incentives already. It wasn't the claimed major driver from the people that we spoke to, but it could be a little bit of a kind of research situational effect on that. People kind of say perhaps what they want you to hear sometimes in these interviews, so need to be wary of that. But I've invented the word transactionalism, because the one thing that I think was clear from our interviews is that they didn't want their participationists to feel like, I'll do this thing, you give me the money, and that's it. They wanted to be a part of something meaningful. We didn't see actually any particular preferences driven by the three diagnoses that we're exploring, which we thought was interesting. We wondered whether different diagnoses might dictate different sorts of comms approaches. Make the practicalities of participation easy and frictionless. Offer choice wherever you can, and that's a key part of Global Minds. I think it stands for anyone involved in research, obviously, but be really clear on how you're going to use the data, who's going to use it, where, why, and for how long. And then finally, again, this has come up this morning, but brands and the reputation of brands really matter. People want to know who is behind these studies, why they're involved, and what they stand to benefit from their sponsorship of these sorts of programs. So that's an important element as well. I'm conscious of time, so I'm going to skip over my last couple of slides, but needless to say, all of this insight is helping us to build and design a really comprehensive comms program and support Crevia with the digital journey that people will take through Global Minds and do right by the participants that we're looking to attract, to make Global Minds inclusive and representative of everyone, so the data that it contains will be of scientific utility and benefit all of us affected by these sorts of conditions in the future. Byron, why don't you finish by giving us a sense of where we're going with Global Minds and what you hope to see?
Yeah, thanks, Tim, and thanks everyone for listening as well. I think I'd just reiterate the points that have already been raised this morning around the need to take a multi-leveled approach to engaging participants for your research that is tailored to the specifics of their, as Tim mentions, cultural norms, the perspective or lens that they're looking at. And that has, the work that Tim's just described has very much informed a multi-layered approach that we're going to be adopting in Global Minds, which will work at a cost-effective, national and in fact global level to maximize the uptake and remove the friction-based barriers to participation. That's a key outcome of this, but conscious as well of the need to take a more focused, local, community-driven approach to ensure that we're doing right by those underserved communities and populations and ensuring that we are making our research as representative as possible. I'd just like to highlight again, I suppose, what the aim of Global Minds is. We're trying to develop a precision medicine approach to mental health for the first time. And in doing so, we hope to drastically improve our understanding of the life-limiting conditions at a biological level, and enable those treatments to be developed in targeted ways to change people's lives. We're launching in April, and we'd love to hear from any.
We might have lost Byron. He was saying he would love to hear from anyone who would collaborate and partner. Sorry, Byron.
Sorry, did I drop out? Signal?
We dropped you a bit. I spoke for you, which is terrible, isn't it? But that you're open to partnerships, and perhaps you can bring up that point in the Q&A as well. We'll have to leave it there. Thanks, Byron. Anna, we'll come back to you.
That's great. Thank you very much, Tim and Byron. That was all very interesting. Can I now ask our other speakers to turn their cameras back on as well, ready for our panel discussion. I would also like to welcome two more fantastic panelists for our discussion that we're going to have now. So first, I'd like to introduce Professor Frank Chinagwundo. Frank is a urologist and a widely published researcher, lecturer and professor. Among many notable career highlights, he has been the chairman of Cancer Black Care for 26 years and has dedicated much of his career to raising awareness of the prostate cancer risk, specifically among Black men. In fact, one of his early publications was the first research paper to show that Black men in the UK have a threefold increased risk of prostate cancer compared to white men. I'd also like to welcome Emma Liddington. Emma is joining us from the excuse me, the Cancer Research UK Cancer Prevention Trials Unit at Queen Mary's University. Emma is a behavioural scientist who's been involved in many projects, many trials, including the NHS Gallery trial that we've heard about earlier today, and is also currently working on the Best for Esophageal trial as well. So thank you very much for joining us, and for all our presenters for coming back now as well. So thank you also to everybody who has posted questions. I can see there's a lot of questions. We will come to as many of those as we can. First question I'd like to ask is actually to Professor Chinagwundo, which is around the issue of trust and health literacy, which is obviously a theme that has been coming up through a lot of our presentations today. So these issues can obviously affect people's readiness to take part in health research. What can we be doing to change this? You know, where should we be starting in terms of changing health literacy as well as trust?
I think in terms of trust, the previous speakers have really given us good insights into that. I think one of the important things which has been mentioned is working with community organizations, because there's a historical mistrust for a whole variety of reasons. There's a concept of trusted messengers and community champions, and we find, particularly in the cancer space I'm particularly interested in, that if you get local grassroots community organizations involved and you speak to them, you also use the churches and other religious organizations, you can start to build that trust. And this was demonstrated very well during the COVID pandemic, where the uptake of vaccination was very low in the Black and ethnic minority communities, and the NHS actually did a very good job by engaging lots of healthcare professionals that reflected some of those populations that weren't taking up the vaccine, and running webinars and seminars and vans in the community and so on. And it demonstrated that if actually you wish to engage and build trust, it can be done. It takes time, it takes effort, and it takes money as well. But if we're serious about increasing participation, then that's certainly a key. In terms of health literacy, I think there's a lot more that we could be doing at school. In the PHSE lessons that all the pupils have to go through, there's a lot we could be doing to increase science literacy. I heard that term earlier, as well as health literacy. And I think further on down the line, that will translate into understanding what research is about. I mean, one of the things we found in East London was this whole concept of randomization is alien to many people. The concept of screening, again, is alien to many people that we speak to. So it takes time and effort to understand that. And the other point I would make, which was I think referenced earlier, is having people who look like you and have shared some of your life experience, that whom you can trust to explain some of these concepts. And I think if you do that, you increase research participation. And I'm particularly interested in increasing the uptake of the screening programs, which tends to be lower. And if we can adopt some of these strategies, and I was very pleased also to hear about reimbursement. This is one of the things I said many years ago to the Department of Health, as it was then, as to how you can increase the uptake of screening, whether it's colorectal or it's breast cancer screening. And at the time, people said, no, you can't do that. That's coercive, and taking away people's autonomy if you're offering the money, which I said was nonsense. But other people carried the day on that. Walking clinics, this is and not needing appointments. So one of the things we did in Newham when it came to raising awareness about the prostate, we set up a prostate community clinic where men of any persuasion could just drop in as they wished and get access to prostate examinations and PSA. And we demonstrated and published actually that if you have something in the community that men particularly can just drop in as they wish, they will use those facilities. And we also know, I was interested to see the van, our Future Health van. Again, we've shown, and that's been published, that if you have like, for example, let's call it a man van that goes into the community and educates men about their prostates, you will get men taking up the PSA blood test. So I welcome the initiatives that have gone towards improving research participation. Thank you.
That's fantastic. So I think, as you said, and as others have said, there's lots and lots of different things we need to be doing simultaneously to make a difference to this. Thank you. Emma, if I can just come to you with a question now as well, please. I think there's often a question about the best ways to design and refine recruitment strategies as well. What can we learn from behavioural science theory models to help us with this and to help us to inform trial design?
Yeah, I mean, it's really exciting to hear all the speakers today, especially Tim and Byron, who've been using the COM-B model. I think there's lots of models that we can use in behavioral science when thinking about participation in trials as the behavior. So the COM-B is a really nice, simple model, thinking about capability, opportunity, and motivation. And I think these models also help us to be a little bit more intentional about the groups that we're looking to include in the research. So it's difficult to apply behavioral science models to broad swathes of the population when you're trying to think about what are the specific drivers or barriers to participation. So using behavioral science model helps you to really systematically think through what are the challenges to taking part, and what are some of the drivers, and how can we explore that within specific groups. So who's most likely to benefit from the research that we're conducting? Who should we be involving in those discussions? Who should we be conducting qualitative work or PPI with to help to kind of design our trials to make them the most accessible? And I think it's also really important to think about kind of continuing data collection and monitoring and evaluation as you continue the trials. It's really nice to hear about our Future Health, the kind of evaluation of the different strategies that they're using, because those will help to improve, research in future and trial conduct in future. So all of the work that we're all doing to kind of see which strategies are most effective will help to improve trials as we continue. So I think lots of that kind of ongoing qualitative work and the observational work to see, what are we actually doing, and is this working or not? Is it helping to improve the inclusivity of our trials? I think is really important to help improve research as we go forward.
That's great. Thank you very much, Emma. So I'm now going to come to a question that was specifically relating to the NHS Galleri trial. So I'll probably come to Laura and Ian first on this, but I think others may have views as well. So as we heard, obviously you did a fantastic job in terms of recruiting people from a wide range of economic backgrounds, male, female, age ranges, etc. But what more could have been done specifically to recruit people from Black and Asian communities, do you think? Was it to do with invitation strategy or more community engagement? What more could have been done there?
Thanks, Anna. Gosh, it's quite a hard question, and in many regards, I'm quite jealous of Our Future Health of test control scenarios they've been able to build to really explore what things really make a difference. I think from what we could see from the needed to invite numbers, the targeted invitation strategy and choosing the right clinic locations is a great starting point, but it does suggest those additional community activities are really important to support people being able to take up that invitation. And I think one of our challenges was, it's not an excuse, but it was during the pandemic, so some of those normal community engagement activities weren't taking place. But I do think we needed to have a better awareness at some of our locations of those different voluntary community sector organisations and engage with them much earlier to make it easier for them to come up for ideas with us to better reach their communities. Don't know if you want to add anything to that, Ian.
Ian, you're in mute.
Sorry. Yeah, we were actually discussing this several weeks ago when we were doing a big evaluation of all the communications and engagement activity we did on the trial. And I was reflecting on some very similar experiences and learnings we'd had from earlier trials we'd worked on years ago, including the Summit study in London and the Uscreen study, where we'd been trying to recruit similarly a diverse population. And unlike Our Future Health, which is a rolling program, when you've got a program that's running to a very tight timeframes where the mobile units are going into a location for a short period of time and then exiting again, you've got to try and do your community engagement work in a timely way ahead of that activity. And we found with Summit and with NHS Gallery that knowing exactly where you're going to be going in good time to be able to begin that engagement work early enough is really fundamentally challenging, and I think that's one of the advantages that Our Future Health possibly has, is that you can learn over time and you can adapt your strategies. So I think there's no question that's a challenge. I think we tried an awful lot of different things to try to make sure we were building those connections with those communities, and certainly by the time we were in the retention phase for those activities, we were trying to get back to communities and get people to come back for their second and third appointments. You could see there were relationships being built and trust forming, but when you're doing that very first invitation for the first time, you're arriving into a location and you're not known to those people and you are just one thing in their lives when they've got many other priorities. There's no question that's challenging, and I think really the best hope we've got is that trials in general, I think there's a need for a national conversation. I think there's what we really want is to be able to have trials like NHS Gallery landing into communities and that feeling familiar to take part in research, it feeling normal to do that, and for there to be more stories shared amongst those communities about the experience and the positive experience of taking part in research, which is where I think the likes of Our Future Health can make a huge difference. But also I think there's a role for organisations like NIHR and others to lead a national conversation around this.
Great, thank you, Ian. Dr. Sesay, would you have something to add, please? Thank you.
Yeah, this is just a really quick point that I wanted to make in terms of language that we use. I was really pleased that I didn't hear hard to reach at all during any of the presentations, because that can be really exclusive. But I just wanted to talk about using the term ethnic minority, because there are some individuals who find that to be quite exclusive as well, because it makes it center around whiteness as the default, and it implies inferiority, lesser status. And if we talk about even the numerical accuracy of using that terminology, yes, it might be within a certain context that those populations are at a reduced number in comparison, but actually in a global context, these groups are global majorities. So I think it's important that we are careful with the language that are used, because that in itself can be a barrier or a detriment, and that's why some people may not come forward. So using things like global majority or racialized community, where we are admitting that actually race is a construct, social construct, underrepresented groups, or like historically excluded groups, just remembering that we don't put the onus on the groups, rather we put it on the services and reaching and the ability to reach the services. So the communities aren't hard to reach necessarily, but the services are, and they're easily ignored usually.
Absolutely. I think that's a really, really important point, and language is so important in all of this. Absolutely. Thank you. So I'm now going to come to one of the questions that's been put in our Q&A. I think probably a lot of people could answer this as well, but it's really about thinking about how we apply the learnings we've heard about today to smaller studies. So we've mostly been hearing from larger trials today who've been able to obviously invest in the larger scale interventions to address the barriers. What are the what learnings from that and what insights would be more applicable to sort of smaller scale studies or potentially studies with less funding? Annika, do you have any sort of thoughts on that initially, or anyone else wants to come to that?
I'm going to sit on that. I might come back to that.
Okay, no, that's fine.
I posted an answer in the chat on this, but I'm happy to expand on it slightly, because we have supported a number of smaller scale studies. I mean, there's no question you need a minimum amount of investment of time and energy to do this sort of thing well. There's no real shortcuts to it, but I do think a lot of the same principles do apply. You need to take time out at the outset to speak to people from the groups you expect to find it harder to recruit amongst, to understand the different barriers that they may face, and to genuinely listen and be prepared to adapt your trial design and adapt your communications accordingly. But that is scalable. If you don't have huge amounts of money to do that, you can do 2 or 3 focus groups. You'll still learn something from that. I mean, ideally you'd do more. Ideally you'd try and take longer to spend, but I do recognise that costs money. And then the other thing I think is it doesn't cost a huge amount if you do that well at the start and you make connections with relevant community organisations that do share your interests, depending on what your trial is about and where you're doing it. If you find a group that shares your interests, then continuing to work with them throughout the trial to allow you to learn and adjust as you go, and again continued listening, I think can make a big difference. And that, yes, takes a bit of time and energy to do it, but it doesn't need to necessarily mean a lot of money.
Absolutely. Emma, can I come to you next, please?
I think if you can have a look at some of the behavioral science work before trial setup and before you have the funding in place, you can see some of the things that have been found to be effective. So like reimbursements, like Frank was saying, and simple things like reminders, you can always kind of incorporate those into your trial. But I think importantly, everyone here has talked about community engagement and continued engagement throughout the trial. And in a way, sometimes maybe having the smaller trials is a little bit easier in that sense because you have a more focused population that you're looking at, and you can more closely engage with the people that will be in the target of that trial. I think some of like Our Future Health, if you're trying to involve or include 5 million people from all walks of life, it can be almost more challenging to engage the right people. So really focusing on who you're looking to involve and making sure their voice is really centered in the research, I think is a good starting place.
Thank you. Annika.
Thanks. Yeah, so just a small build on what Emma and Ian have said. I think the thing that is something that we are increasingly focusing on, but I think it really offers a sort of a more sustainable and scalable solution, is sort of more community partnerships. So of course there will be some time and energy that needs to go into that, but I think that it will be impossible. I mean, Our Future Health included, it'll be impossible for us to understand communities, to engage and reach communities in isolation. And we need to be working with others. And these key community organizations are, they understand their communities. They know what barriers they face. They'll be able to help us understand them, and then we can it's a sort of a two-way working relationship, and it's something that we are looking to do a lot more, and it'll really help us do that. But I think that's a really I would encourage people to be sort of looking at community partnerships. So I do think that can add a lot of value for these types of recruitment studies.
Thank you very much. Professor Chinagwande.
Yes, I was going to make the point of about the researchers themselves, particularly those where the funding comes from, maybe the MRC or the NIH. One of the things, as a researcher in terms of recruiting to studies, I'm talking about kind of clinical studies, is that if it's more difficult to recruit someone, then you don't do so. So when you're in a clinic and there's a trial that you could recruit into, if you think it's going to take you half an hour to explain the ins and outs, then you tend to pass on that and then recruit someone who it's easier to explain and who gets it, with the inevitable result in that the people that you recruit are very biased. And it's always struck me that there's no, I'm not sure penalty is the right word, but there's no consequence to many of these big studies where recruitment has not involved the communities it should involve. And I refer particularly to a huge prostate cancer study many years ago, which cost something like 32 million. And looking at whether you do as well surveying your cancer or having surgery or having radiation. And despite the fact that black men are 2 to 3 fold more likely to get prostate cancer, less than 1%, and this is a UK funded study, less than 1% of the participants were actually black. And it's because the recruitment was not in areas where there were many black people, and also insufficient effort was given to actually understand the barriers and put the effort into recruiting them. So I think there has to be something on the side of the research community, and particularly those who are funded by large organizations, to say you have to actually take an interest in and widen participation, or your study won't get published, or something like that. There's no stick.
Okay, thank you, Dr. Sesay.
Sorry, and just to add to that, also in the materials that the researchers or the pamphlet leaflets that they're giving to the patients in order to recruit, you need to be careful that, or at least intentional, that it includes images that look like the population that you want to research. So the reason that I carry around this brown vulva is because mine is brown, but also you do not see that. You don't get that visibility. The representation isn't there, and representation matters. And if you can't see, you can't be it. I know a lot of Black women who were diagnosed with breast cancer shocked because they didn't realize that Black women could get breast cancer, because as far as they're concerned, all of the campaigns and the leaflets and the adverts that they'd seen about Black breast cancer involved white women. So it's really important that when we are putting things together, that we have diverse visualization. And I'm not just talking about ethnicity. I'm also talking again about marginalized communities that include disabled individuals, those from the LGBTQ plus community, and so on. We need to be inclusive and very, very intentional in those sort of things.
Absolutely. Thank you very much. Thank you. So I'm just going to move on to another question. We've obviously talked quite a lot about the importance of working with community groups to help us to reach communities that we want to involve in research and trials. So obviously these groups, they get lots and lots of requests all the time to be helping with really, really well-meaning projects, but they're often quite small organisations, perhaps not very well funded themselves. They might lack resources to be helping in a significant way. So what can we really be doing to help with this and maybe support those organisations and incentivise those groups more to be helping with this kind of thing as well? Annika, I don't know if that's a question that you'd be happy to answer. Thank you.
Yeah, that's a great question, and it's something that the team experienced quite early on when we were trying to collaborate with community organisations. I'd probably say 2 or 3 things on this. So one of the things that we find helpful and that works is that it's sort of flexible, or offering flexible involvement and ways of working. So with the organisations that we've worked with so far, we're very much led by them and how they want to work with us, and that might involve communicating over WhatsApp. It might, in sort of, for us to feel comfortable that reporting will look different, or it might be, evening meetings, whatever it might be. We're very much flexing how we work internally. I think the second point I'll make, which feels silly to state, but I think I've sort of seen it get forgotten in sort of past instances, is that we very much focus on sort of 2-way collaborative partnerships rather than transactional relationships. So, rather than us sort of saying we want to work with you because, X, Y, and Z, we we make sure that they're getting value from the relationship, whatever that might mean for them. And that we have found that to be different for every organisation that we're working with. So we do make sure that we focus on that. But sometimes some things like this aren't enough, and we know that there are resourcing or funding issues. So one of the things we're actually actively exploring this year is developing a community fund at Our Future Health. So it would essentially be a pot of money that smaller community organisations can apply for if they're really interested and keen to work with Our Future Health and sort of behind our mission. So yeah, TBC on what that looks like, and hopefully there'll be more on this year. But we are hoping to do this to really enable further and deeper engagement with underrepresented communities.
Great, thank you, Annika. Byron.
Oh, I think Ian had his hand up first. I'd be very happy to defer.
I've spoken already, Byron. You go. I'll go after you.
Okay, great. Well, thank you. I was just going to draw in another point that actually I think Tim has mentioned on the Q&A, which is interestingly in reaching out to some of these community organizations, certainly our experience is that many of them don't feel very consulted a lot of the time, and so actually they welcome the outreach. And to echo Annika's point as well, engaging them with on a bespoke basis to understand what it is that they're working with, what are their challenges, what might they see out of a mutual relationship, rather than coming to them with a transactional ask to say, we need help recruiting, send this message out. It's more like, your communities the best. How can we work together to achieve a sort of aligned goals? And then, yeah, as Annika says, working on what are the challenges they're facing and how can we be part of the solution for them as well.
Thank you. Ian.
Yeah, not much to add. I agree with everything that's just been said. The one thing I just wanted to reflect on that can be a challenge, and it's worth people being aware of it. It's the challenge it poses is doing that engagement and providing material to help those organizations communicate with their audiences whilst ensuring you've got ethics approval, because it's a phenomenal challenge, because ethics approval takes time. And if you're going to genuinely try to work with those community organizations and communicate with their audiences in ways that they're used to doing and are comfortable with, you need to plan well ahead to understand what's the kind of content they're going to need. How can they be worded in such a way that's going to get ethics approval but still be suitable for them? And with NHS Gallery in particular, spent a lot of time developing and iterating, and I know Laura's got a hand up and we'll spent a lot of time on this, very flexible toolkits for those organizations that gave them a range of options of ways they could use that content. Even having done all of that, it was still a little restrictive, and you have to be aware of that being a challenge. And so making sure when you first engage those community partners that you can explain those restrictions and explain the reasons for them is also quite important, I think.
Thanks, Ian. Thanks, Ian. You've actually covered a lot of the points very clearly there. I think I'd just add to that in saying, initially, I think we were very ambitious in what we hoped some of the community leaders would be able to do for us. And those toolkits, in order to try and create that flexibility, were quite large and had many different options. And I think actually we learned that was quite overwhelming. So to some extent, we need to do some work ourselves to really prioritise what are the top message we would really appreciate your support to convey, to really reduce those toolkits to make them more manageable so that they would be more easily used by the community leaders.
Absolutely. Thank you very much. That's great. Thank you. Okay, I'm now going to come to Byron with a question specifically for you and about your work. So obviously creating a representative cohort among people with serious mental health problems is very ambitious in itself. Coming back to what Dr. Desai was talking about earlier in terms of making sure we're being fully inclusive as possible, what's helping you to do that?
It's a really good question. I'm going to try and answer it, but I'm going to draw in some other themes as well, because we have to work with the constraints as well of other factors. So it's known in our field that particular neuropsychiatric conditions disproportionately affect people depending on their genetic ancestry and ethnic background. For instance, Black men have a higher prevalence of schizophrenia and psychosis-related disorders, but are underrepresented in the research around that therapeutic area. And so really, that's a specific nuance around our condition area that's definitely a challenge to work with. We have a constraint with Global Minds that we also, to make this data set three-dimensional, we need to have access to the electronic medical record of these patients. And so it's not just about the prevalence of these conditions in these populations, it's their access to care and the availability of their clinical records that mean we can include them in our research. And so that's a separate challenge in and of itself, because we're constrained by whose electronic medical records can we access, and that is driven by whether they access that care, if that makes sense. So we can't impact the upstream challenge of whether these underrepresented groups are accessing the care that will put them in our path for this program, if that makes sense. All we can work with is how can we best enrich and maximize the representation within the community that are accessing care and whose records that we can access through our NHS partners. And that comes back to the same point that we've articulated already today, which is around taking a multi-layered approach to engagement, leveraging the access. Access sounds a bit impersonal. It's leveraging the relationships and the one-to-one knowledge that these local community organizations and healthcare organizations that interact with these people as people, not just as stats, to ensure that we can bring our research to them at a personal level, while simultaneously trying to remove the access barriers and make it as frictionless as possible for as many people as possible. So it is being conscious that there isn't a one-size-fits-all approach, and taking targeted approaches that are driven by the specific needs and considerations around those populations.
That's great. Thank you very much, Byron. And just picking up on some of what you said there, I'd like to come to Emma with a question now. So obviously lots of recent studies have been looking at inclusivity of trials in relation to specific demographics. It could be to do with ethnicity or other demographics. And it's been challenging to answer the questions just because of the amount of sort of data that's missing. Actually having that data in the first place is hard to come by. So what sort of data should we be collecting about trial populations to be able to tell if actually our trials are really inclusive or not? Oh, Emma, I don't think we can hear you. Doesn't look like you're on mute, but
I did just come off mute. Can you hear me now?
Yeah, we can. Thank you.
Yeah, there was an interesting NIHR diversity data report recently where they looked through all the NIHR HTA trials, and they found that only 60% collected ethnicity. So it's really difficult to determine whether or not our trials are being inclusive. And we did look recently also at whether or not trials were collecting disability, so like self-identified disability, and none of them collected this as a demographic characteristic. So I think it's really challenging to see beyond age, sex, and sometimes ethnicity, whether or not we are being inclusive. And I saw from Ruth a question in the chat that asked about intersectionality, and I think it's one of the big challenges because it's really important when we think about whether or not our research actually benefits certain populations. And if we aren't able to look at intersectionality because we don't have that data, we won't be able to answer those questions. So I think going back to my point of kind of continually monitoring and assessing who's in our research, which groups are we missing, it's important to collect demographic data beyond just age, sex, and ethnicity. And there's lots of kind of challenges to that. There is a study called Include, and they looked at the best way to collect ethnicity, and that's really just a free text answer because none of the characteristics that we have or the categories that we have really reflect, people don't feel they reflect themselves. But at the same time, qualitative data or free text data can be really challenging to code and analyze. So I think there's a big issue here in terms of how we collect demographic data and something that's not been answered. There's no sort of guidance on what we should be collecting and how we should be collecting it. So we've kind of done a recent project looking at sort of existing questions based on national surveys like the census and the Family Research Survey and tried to identify the best questions. And we did a big kind of public consultation with diverse members of the community to see what they thought in terms of the questions. And it's not perfect, but we're looking to introduce that into our new trials to kind of assess, what do our populations look like? in terms of a range of different demographic characteristics. Who are we missing? And are these questions that we've come up with actually working? So yeah, I think it's something that we should all be doing better. And I think is being encouraged. I saw someone else mention that the NIHR is making it part of their requirements for funding. And I think they're also going to make this a requirement for reporting. But we need to think about how we should be doing that better. And I don't think there's a clear answer on the best way to do it at the moment.
That's great. Thank you very much, Emma. I'm just going to, I've got one more quick question, which I'm going to come to, I think, Dr. Sisay on, which is, I think in a lot of the work we've done, we talked about trusted messengers, and trusted messengers can include healthcare professionals, GPs, other healthcare professionals as well. So what role do you see GPs and other healthcare professionals playing in trying to address this inequity in health research?
Yeah, I mean, obviously, as a GP, we know that we are basically the gateway into the NHS. We are the front line. We're usually the first port of call for a lot of patients. And if they've had a pleasant experience, and I'm going to say that, I'm prefacing that because I know there's some people who've not had the great experiences with their GPs, and that can affect the trust. But if they've had great experiences with their GPs, we could be the ones who, if we are involved with the research, we could be involved in helping recruit patients into certain trials, especially if we feel that they are of the best group to be involved. So we could educate and inform them about the studies that exist where we have time, if it's possible, or at least we can get consent for them to share their information so that you guys can recruit them. But absolutely, I do believe that we can play a big role. Just really quickly, because I saw this in the Q&A, I just want to quickly answer this. What does the panel feel about the use of social media to best recruit patients? I feel like people really sleep on social media. At the moment, social media is so big in terms of health awareness, health literacy. There's a lot of misinformation, disinformation, but it's important that you have healthcare professionals and those of expertise to be in it. And actually, it is a means, of recruiting people. So for instance, I've been supporting 5 Times More, an organization that deals with Black maternal health, and they've recently released a survey called the Black Maternal Experience Survey. And within the first day, they got, I believe, 500 to 1,000, something along those lines, people respond just through social media. So it is a means potentially, because more and more people utilize social media, and it is a means to get or recruit individuals who you probably would not have access to alternatively.
That's excellent. Brilliant. Thank you very much. So sadly, we're now out of time, so we're going to need to wrap up. So I'd like to say a huge thank you to all our speakers and panelists today. It's been a really, really interesting discussion, and I'm sure everyone has got a huge amount out of it. Thank you also to everyone who has been listening today and has been sharing questions as well. If you've enjoyed what you're hearing, please sign up to Clare Mail, which is on the Claremont website, or you can follow us on Blue Sky or LinkedIn as well. I think the links for those should be going to the chat. If not, so they're available on our website. So Clare Mail is a newsletter we send out every couple of months. We don't sort of spam you with it. There's not loads of it, but that's the first place you'll hear about events such as this. So if you have any comments at all or any feedback about today's session, please do drop us an email. We can be contacted at hello@claremont.org.uk. But otherwise, that's it for today. So thank you very much, and I hope everyone else has a lovely rest of the day. Thank you very much. Take care. Bye.
Thank you. Bye-bye.